Hello, again, it's me. Sorry. Okay, so you felt my passion about the uterine peristalsis. So this is my second patient. That, in fact, I'm the endometriosis and ultrasound coordinator in Instituto Bernabeu. However, I'm IVF specialist. You know, I'm not sonographer, guys. So I try my best. And I think you apologize me if I'm wrong with something. But again, thanks to Angela, because I think she thought in me when they did the speeches, and I know that she cares a lot about me, so thank you very much, because I have the opportunity to talk the role of 3D ultrasound in the evaluation of endometriosis. So if we think how we assess the endometriosis, over the last years has changed a lot. Thanks God we have improved a lot. Even in deep endometriosis, I'm not talking a lot about the ovarian endometriosis because it's easy to diagnose ovarian endometriosis. You need to wait over the time, and if there is a cyst, great, this is an endometrioma, no? So the most challenging is to diagnose deep endometriosis, and probably well, the best was this approach that the IDEA group did in 2016 that allows even in junior sonographers to assess and to try to diagnose this deep endometriosis. So really this methodology helped a lot to diagnose it. However, sadly, we still have a delayed diagnosis. I can't believe it, but it's true. We have delayed diagnosis that is ranged between 2 and 9 years with an average of 5 years. Obviously, the delayed diagnosis of 9 years is in deep endometriosis, and it's very difficult. And this is affecting directly to our population. The infertile population is not diagnosed, and we need to diagnose it. Why? Because if you see this paper, this is one. The 44 in the population of unexplained infertility patients, almost 44 patients were diagnosed later on of endometriosis, 10% with a serious endometriosis. So these patients that diagnosed of unexplained infertility is not an unexplained infertility. They have endometriosis. And why is so important? Because endometriosis patients, despite there are a lot of controversial, probably has worse outcomes in reproductive medicine. And we need to counsel them properly. We cannot tell them that it will be as easy as a 12 factor, because probably not. What we know about endometriosis is that we need more embryo transfer, more treatments for having this pregnancy. That finally they reach the pregnancy. It's true, but they need to pass through all these treatments more than other diagnoses. And the timing is important. It's not the same, the outcomes in patients diagnosed before the treatment than after the treatment. Even more, the patients diagnosed before, they have lower numbers of treatments, better pregnancy rate, finally, better everything, you know? So we need to diagnose our patients before the assisted reproductive techniques. What we know so far is that the diagnosis is better performed in specialized units. In this study, I don't remember if it's in Netherlands or in the north. Okay, they do this, all the patients have done this ultrasound in this specialized unit, and what they discover is that over 22% around 22% of the patients had endometriosis, but most importantly, 16% of them had a new diagnosis. They didn't know that they had diagnosis, and they were going to an assisted reproductive techniques without knowing that they had endometriosis. And this is so important. So we need these units, specialized units in reproductive medicine. Could 3D ultrasound help us? Okay, to be honest, when I've made the research, putting 3D ultrasound and endometriosis is very poor. Only Guerrero has published it, and it's very controversial. There is another that says that 3D is not doing anything. To be honest, Guerrero has published that you can assess better the deep endometriosis, and even the learning curve is better. But if you cannot do a good 3D ultrasound without 2D ultrasound. If you are not seeing anything, you cannot do 3D. So I'm not sure if the 3D can diagnose more. What can do is confirm better the image that you are seeing in 2D. You can assess it better, measure it better. You can make it especially with the another structures. So you can see better if it's affecting the bladder or the bowel or whatever. And is how it's helping probably 3D scanning. And how? Well, this is, I think it's helpful for the practices too, but this is the modes that we have in 3D that can help in endometriosis. I try to focus all these modes in every endometriosis situation and how can it help. So we start with multiplanar. Remember, multiplanar mode is the first mode in which we can see the 3 orthogonal planes. And first, this is the first mode that you have to do. Why? You see a deep endometriosis, but you are not sure because it's like a black image. And so if you make this multiplanar mode and you can see the image in the 3 planes, so for example here, here, and here, is something real. Because you can see artifacts, but in multiplanar not. If you make this 3D, you can see it. Also in the bladder. So again, in multiplanar, you can assess also the septum. I like a lot to do this image because it allows me to see in very down the rectovaginal side septum. And you can do TWE later on and everything, but this first image really is very clear. That the vagina, the rectum, the urethra, And in the another one, you have a deep endometriosis in which you can assess it through all the multiplanar modes because you can change the color, you can change the BCI, everything. Okay? And here, can you see how is the bladder, the bowel between the endometriosis and the ovary? Really, it surprised me because I didn't expect that. I only see it once I had this 3D, and I suddenly saw that it was very close to the ovary. In fact, this is thicker. So moving to another mode, we have the render mode. Okay, most of I think the doctors that specialized in endometriosis, first they don't like 3D. So we don't have any issue with them. But the worst that that for sure that they don't like is the renderization because they don't see the utility, and it's possible. I like the images, but probably it's not useful for diagnosis, it's not useful for anything. However, it's true that when you have endometriomas, sometimes you can see or you can feel the tissue inside, and you can see better how is the depth of the levels, for example, here and here also. But it's true that you can obtain better images with another mode. However, I like them. You can move the light and you can see all the tissue inside the ovary. So probably I'm going very quick. All right. So we are moving to the vascularization. I think always that you see some endometriosis, endometrioma, you have to assess vascularization. Why? Theoretically, the endometriosis hasn't been very vascularized. So you mustn't see the crown vascularization in an endometrioma, for example, or in this deep endometriosis vascularization that is going inside. This is a bad sign. And this is also a sign that probably this, if it's not a malignancy, is because the endometriosis is growing up. So it always helps you to assess it better. So if you see vascularization, probably you need to assess tumoral markers. You need to assess again the patient in a close time, in less than 1 month, to see if it's changing something. Because it's true, or if it's clear, go to the surgery, you know. But it's true that always we need to assess the vascularization. If it's in 3D, better. You know, I'm 3D sonographer, so I think with 3D it's clearer than 2D. Also in 3D you can differentiate between endometrioma, this is an endometrioma, of corpus luteum, hemorrhagic corpus luteum. Why? Because this is the crown, okay? And sometimes endometriosis, because in fact it's published that it seems that the hemorrhagic corpus luteum is like the beginning of endometriosis in some endometriosis patients. And I don't know why, I don't know how, but it's true that can happen. So it's true that always that you have that and you have an endometriosis typical patient, probably you need to follow up to see if really it becomes an endometriosis. But at the beginning, when you see that, you have to think that probably it's a hemorrhagic corpus luteum, and then to follow up the patient to see if really it disappeared. So moving to one of my favorite is TUI. You know, because it's like a CT. And patients not always believe that we can do that with ultrasound, but we can do this even better sometimes than MRI or CT, and it provides really useful images, because with that, for sure, you can diagnose it better, and you can see all the neighbor structures, and you can measure the distance also with the other structures. So in this video, you can see how I start always. This is a deep endometriosis. I started with render. Also, this is the multiplanar, and you can see how the endometriosis is affecting the bowel. In TUI, you can see the depth or how it's affecting in the width of the bowel and in the depth too. So with that, you can if there is some infiltration inside the bowel, you can see it. And even if it's passing the lumen of the bowel, you can measure it. So really, it's very, very useful. But of course, before to do the 3D, you have to see it in 2D and take a good image in 2D, because otherwise it's impossible. And moving on, this is I discovered vocal and soon ABC, the utility of it in endometriosis probably later, but my interest was that I needed to follow up the deep endometriosis and how to assess it. It's impossible, they are very regular, and how to measure, you know, and I needed to want if they were growing up. So I always telling everybody that I'm touching all the buttons of the machine, trying. I try it, and then if it's something that is useful, I repeat it. So in my daily practice, always, mainly deep endometriosis and sometimes endometrioma too, but In endometrioma, when they are circular, it's easy to measure and more or less to see if it's growing up. But in deep endometriosis, I started doing vocal, but not manual because I'm doing with the patient. I started doing vocal with semi-automatic, you will see here. Well, is here, is one of them. But also the SON-ABC, I started doing in hydrosalpinx, of course, in antral follicles, but also in the deep endometriosis, and this is the best. If I can, always I'm using SON-ABC, follicular SON-ABC. Why? Because it provides me all the measures. Remember the species of SON-ABC that you can see all the measures of the volume, even the mean diameter, and this is very useful to follow up the patient. Of course, always I have to write the volume, and to see if the volume has been made in vocal, I have to write is vocal, because semi-automatic vocal, for example, under-measure the structures, and the SON-ABC probably is the most exact for me when I could it. So here you will see that in this video how I'm doing SON-ABC. So sorry, because the speed is very quick. And I think I was very quick, sorry. So, in take-home messages, I would like that you feel after this that really 3D can be helpful in everything. And you don't be afraid to use it, even with endometriosis or whatever, because you don't lose anything doing that. Only can help the patient, can help you to confirm what you think about the patient, and can provide you images that the patient probably will thank. So obviously diagnosis matters, not only because it can affect the life of the patient, can affect the outcome of our treatments. The role of 3D ultrasound, it remains controversial, as I told you. However, yeah, you need to try it, and I encourage you to try to do everything. And yeah, you know that the tools that you have already learned in the practice, but remember that the volumes assessments really can be useful for everything, even with endometriosis. And that's it. I hope you like it.